So I wanted to go over disorders of the breast. There's 2 in the benign disorders and 1 for the malignant. Fibrocystic breast disease and specific benign neoplasms. And then for the malignant disorders, we're going to be talking about breast cancer. We know that benign is going to be your more non-cancerous tumors, and then malignant is going to be your cancerous tumors. Metastatic would mean that essentially the tumor or the cancer is going to be spreading throughout the body. It's going to be invading tissues, nearby tissues, and whatnot. So the benign disorders, it usually is non-invasive and it's non-metastatic. These tissue changes that are non-metastatic and non-invasive, things like cysts, fibrosis, benign epithelial or connective tissue growths. And then the malignant disorders involve more abnormal, invasive epithelial cells that divide and proliferate, and it has the potential to metastasize throughout the lymphatic and vascular routes. This is going to set the stage for understanding how hormonal regulation and how the ducts are structured, connective tissue and lymphatic drainage drives the pathophysiology of all the conditions that we're going to talk about. With fibrocystic breast disease, this is going to be caused by a hormonal imbalance during your reproductive years, and it's going to lead to an exaggerated breast tissue response to estrogen and progesterone. So just what I said there, it's going to lead to an exaggerated breast tissue response to estrogen and progesterone. So what does that mean? If they have too much of that estrogen and progesterone, it's going to get worse. So if you see a test question that says give them more estrogen and progesterone if they have fibrocystic breast disease, that is the incorrect answer unless the question is specifically asking for that. This is going to result in multiple lesions of the breast, so make sure you know that. It includes cysts, ductal dilation, fibrosis, and these cysts can enlarge or shrink with a menstrual cycle because they respond directly to the hormonal cycling, essentially. It just depends on how much of the estrogen and progesterone in the body there is. Behind these tissue changes, the estrogen stimulates the ductal epithelial growth, essentially, how it divides and proliferates. And then the progesterone, it stimulates tissue growth as well. So whenever the sensitivity is heightened, these ducts become distended, forming microcysts and turning into macrocysts. One thing to note is that whenever these cysts occur and these ducts start to stretch repeatedly, it can rupture and it can turn into fibrosis. This is essentially what this condition is. And it's identified by self-breast exam. You can see nodular and mobile masses. You can do mammograms and detect differences in the density of the structures. And then you can also do an ultrasound. Tissue biopsy, again, with any kind of change in the body, tissue biopsy is going to be the most definitive out of all of them, but just remember that is also the most invasive. So ultrasound with needle aspiration, it can help distinguish between if it's fluid filled versus if it's solid. And then as far as treatment goes, yes, you can have oral contraceptives that helps regulate hormonal cycling, because again, this gets worse with your estrogen and progesterone being super high, and then it can cycle through if it's also super low. It just depends. So that's why oral contraceptives helps regulate it through the hormonal cycling. It reduces the overstimulation of this condition. And then NSAIDs helps with just the inflammatory component from the tissue stretching. And of course that can help with the pain as well. What you can do as well is do heat compress and a supportive bra, which helps reduce the irritation from the breast mechanically stretching downward from gravity and weight, of course. You can also do a low fat intake. This decreases the overall estrogen levels where the fat stores estrogen. And then high carb diets. It increases fiber, and this helps decrease estrogen reabsorption in your GI tract. And then you also want to tell the patients to avoid caffeine because there's a substance called methylxanthines, and it can be found in food and plants, and this increases breast sensitivity, and it may just make the pain worse. It's going to aggravate it. So avoid caffeine, avoid methylxanthines. Some of the examples would be tea, coffee, chocolate. If you see that, and if you see theophylline, theobromine, caffeine, it's gonna worsen the pain. So make sure they avoid that. Just know that oral contraceptives suppresses endogenous hormonal fluctuations. Higher carbs means more fiber, and then low fat helps decrease steroid hormone production or processing. And then as far as what you'll see pain, tenderness before menses, menstrual period, due to the increased fluid retention. You'll feel palpable cysts. They can be firm, smooth, regular, and mobile. Remember that. So, specific benign neoplasms. Neo meaning new, plasms meaning growth. So new growth. With these benign neoplasms, these benign tumors, they come from localized cell division or proliferation. It stays encapsulated and it doesn't invade and it doesn't metastasize to other structures of the breast. Fibroadenomas are going to be one of 3 of the common benign neoplasms. So the fibroadenomas, they're commonly found in the ages 15 to 35, and it comes from fibrous and glandular connective tissue. This is going to be hormone responsive, and you'll see that this is going to be a main theme for these conditions. Hormone responsive just meaning that too little or too much of these hormones is going to decide on how severe this condition is. With fibroadenomas, it's going to be well circumscribed encapsulation, meaning just well defined. It's going to be round, it's smooth, it has a rubbery feeling, and it's freely movable. With adenomas, it's going to be less connective tissue involvement than fibroadenomas. It more so comes from the glandular tissues. It's also going to be encapsulated, also going to be non-invasive. With papillomas, this is going to come from the epithelial lining inside the ducts, and an overgrowth of this is going to be leading to duct obstruction and discharge. And if there's going to be a lot of irritation and disruption of the duct, it can also produce bloody or serious nipple discharge. And as far as the diagnosis goes, of course you can do a breast exam. That's going to help detect whether something else, or it's going to help detect those discrete encapsulated masses. Mammogram can also help visualize well-defined lesions to help with your diagnosis. And then, just like with anything, biopsy is going to be the most confirmatory test, but again, it's also going to be the most invasive. This biopsy with ultrasound can confirm the benign cellular traits of this condition. For the clinical manifestations, again, it's going to be freely movable because the benign masses don't invade the surrounding structures. So just know, papilloma, the origin is going to be coming from the nipple or the ducts. Adenomas, it has an origin in the glandular tissues. And then fibroadenomas, it's going to be coming from fibrous connective tissue. Next thing, breast cancer. So this is going to be the malignant condition. So breast cancer, it's a malignant transformation of breast epithelial cells. It's going to lead to uncontrolled division, uncontrolled proliferation. It's going to invade the surrounding tissue, and it has the potential to metastasize to other parts of the body through the lymph nodes, and yeah, it's going to be really invasive. It's going to be commonly start in the ductal epithelium. It's an invasive ductal carcinoma is what it's called. And the upper outer quadrant is going to be the most common because it contains the most glandular units and lymphatic system. So just like what you see here in the picture, upper outer quadrant is the most common. As far as how it's going to spread, proximity to the lymph nodes, it allows for it to rapidly invade that area. And then the malignant cells can enter the ducts, the lymphatic system, or the bloodstream. For the clinical manifestations, you'll see a hard mass. It's going to be caused by fibrotic changes, fibrotic reactions around the tumor. So it's going to be a hard mass. It's going to be painless early, and the nerves are displaced, not invaded. It's going to be poorly movable. So unlike the other conditions where it moves freely, this doesn't, because it infiltrates the surrounding tissue. If you think about it, if it infiltrates the surrounding tissue, there's a lot more attachments for it to not be able to move. So If it invades, that means it's anchored down, poorly movable. You also see some skin dimpling. The tumor, it pulls on some ligaments called the Cooper ligament. That's what's going to cause the skin dimpling that you'll see during a breast exam. And then you'll see nipple retraction as well. The tumor contracts on the ducts, causing that nipple retraction. The bloody discharge, it'll be the advanced invasion of the ductal lining, causing the irritation. So the breast exam, just like with the others, it can help detect the structural abnormality, the structural distortion. The mammogram is going to help see the well-defined lesion, whether it's a well-defined lesion or whether it's invading lesion. It'll help identify calcifications and the masses. And the mammograms need to start at the age of 40 because then your risk increases after you reach 40. And with the ultrasound guided tissue biopsy, again, biopsy is the most confirmatory, so this will help confirm the cellular changes. With the MRI, that's going to help evaluate the extent of the disease and the lymphatic involvement. So if you wanted to know how severe this is and if it's invaded other organs or tissues in the body, then MRI is the way to go. So just know, invasive ductal carcinoma, it's going to be the most common. There's also something called DCIS, which is ductal carcinoma in situ, meaning stays in place in situ. Ductal carcinoma in situ, or DCIS, is going to be non-invasive. These are malignant cells that are non-invasive, and it's confined inside of the duct, but they haven't spread into the surrounding breast tissue. So I know we said already that with breast cancer, these are cancerous abnormal cells, and it invades local areas. But just know that as far as ductal carcinoma in situ goes, this is going to be non-invasive. It's still malignant and it's confined inside the duct, but it does have the potential to spread, but they just haven't yet. So how do I do a self-breast exam? Or should I say, when should you do it? Because I know y'all probably already know how to do a self-breast exam, but the most important thing about this is, when should you do it? So this slide just essentially shows the different things that you can see during a self-breast exam. Remember, the dimpling here is caused by the ligaments pulling on the skin, and flattening of the nipple is when the tumor constricts and causes that flattening. So when should you do this? A few days after menstruations. It says here 5 to 7 days. So a few days after menstruation, when you're premenopausal, and this is because the breasts are less tender and swollen. And for those who have reached menopause, perform the exam on the same day each month, just to be consistent and to see if there are any changes to the baseline. We talked about dimpling and the flattening of the nipple. You'll also see some nipple discharge in malignancy. This is going to usually represent an advanced involvement in the ducts of the breast. With the redness, that's usually going to be just inflammatory response from the invasion of the tumor. And with the lymph node changes, just remember it's going to be metastatic spread, or it could be also a reactive hyperplasia. And with the lymph node changes, remember upper outer quadrant, because that's going to be the most common site. When you see swelling, usually caused by obstruction in the lymphatic ducts, and it causes edema. So it says here that cysts are commonly found in women who are menstruating and are usually well defined and freely movable. I would just take a look at the slide, see how to do a self-breast exam, and when's the best time to do this. And this slide just talks more of the same of what we've already discussed, the different signs of breast cancer with the lumps, the nipple discharge, the dimpling. You'll have some breast or nipple pain, and then the retraction of the nipple. You can see some redness, as well as skin texture changes, so that's important. You'll see lymph node changes and, of course, swelling. And it says here to figure 33.10, it says half of malignant tumors occur in the upper outer quadrant of the breast, so just remember that. So what are the risks of breast cancer? Well, unfortunately, there's a lot. So you have your hormonal factors, your reproductive factors, factors in how your diet is throughout your life, family history, as well as history yourself of cancer, and exposure to radiation, and of course your age. So as far as hormonal factors go, if you've had more than 40 years of menstrual activity, you are at twice a higher risk for developing breast cancer. Now, why is that? Just remember, breast cancer is a condition that's hormone dependent, or it depends on how your hormones are throughout your life. So with prolonged estrogen exposure in more than 40 years, it gives your body or your breast tissue cells time to have more proliferative events, more time to divide, which that increases your risk. And that goes also into early onset menarche. I think that's how you say it, menarche. So this is typically before the age of 12. I believe it's like more commonly found in the years of 8 to 9 years old, but early onset menarche. So same concept. You have estrogen exposure, but this time it's earlier. Now that's going to develop a higher lifetime risk because you're just going to have more exposure to estrogen, leading to more proliferative events. And so what about hormone replacement therapy? So same thing, you are increasing estrogen stimulation, which increases your risk of developing breast cancer. Now, with the reproductive risk mechanisms, if you're giving birth less than 18 years old, it helps reduce your risk, but when your first birth is after the age of 35, it increases your risk because breast cells remain undifferentiated longer. Now, what do I mean by that? So with normal breast tissue, normal breast cells, it has a specific function. They're supposed to grow, they're supposed to mature, and they're supposed to take on a specific job. So undifferentiated cells in the breast, they never mature. So they stay in their primitive stage, and they stay disorganized. That disorganization leads to cells dividing faster, and it ignores normal controls on what it's supposed to do, and it doesn't act like normal breast tissue. So the less differentiation, or the less differentiated a breast cell is, the more aggressive the disease typically is. Low parity, that is also going to increase your risk. So fewer cycles of differentiation, essentially, the higher your risk. Breastfeeding also helps reduce estrogen exposure, and it helps promote differentiation. So that's something that you can teach your patients. So breastfeeding reduces your risk of breast cancer. It helps reduce estrogen exposure, helps level up those breast cells to be mature and be organized and take on a specific job, and all that lowers your risk. And as far as dietary factors go, high fat diet, that's going to increase your BMI, and that's going to increase the adipose tissue, also leading to increased estrogen production. And you already know, the more estrogen you have, the higher risk you have. So that's the main theme of this. And as far as the genetic or family history goes, there are, just remember, the BRCA1 and BRCA2 mutations. That impairs how your DNA repairs itself, and that'll just increase the potential for malignancy. It says women who have a family history, mom, grandma, sister, aunt. So if you have a sister with ovarian cancer, that'll strongly suggest BRCA involvement. I would remember that. So it's underlined, of course. So they should be tested for gene mutation. With all of this, just remember, if you have early menarche, it raises your essentially estrogen years and increases your risk through prolonged exposure. And breastfeeding helps decrease estrogen exposure. And remember, with the family history, if there's women who have a family history, it increases your risk, so they should be tested. BRCA1, BRCA2. BRCA1 and BRCA2, these are essentially tumor suppression genes, and they're responsible for DNA repair. So when these genes mutate, they create instability in your breast cells. And of course, this instability is going to increase your susceptibility to breast and ovarian cancer. So some of the preventative measures include salpingo-oophorectomy, and that's essentially removing the ovaries. It's going to remove the ovarian estrogen source, because the ovaries are responsible for producing estrogen. And like what we talked about, the more estrogen exposure you have throughout your life, the higher risk you have. So just removing those guys out, or girls, removing those girls out removes the source. That'll help prevent it. And then bilateral mastectomy, another radical solution. It just removes the high-risk breast tissue. And then you also have what's called selective estrogen receptor modulators. These are chemoprevention. An example would be like tamoxifen. And the way this works, it blocks estrogen receptors and helps decrease the proliferative signaling, or the division, in the breast tissue. So just remember, SERMs, that helps block estrogen in the breast tissue specifically. So the example for that is tamoxifen. And then one of the more prophylactic effective procedures would be the salpingo-oophorectomy, where the ovaries, they're the primary estrogen source. So removing them lowers your risk substantially. So this is a good segue into genetics and the concepts of aging, because we're going to be talking about genes, and we're going to be talking about Punnett squares and all that stuff. So I will see you guys on Wednesday, and have a great rest of your break, and I'll see you soon.